the role of artificial intelligence and its applications in healthcare. We have the great pleasure to have with us three distinguished speakers. We have Professor Dimitris Bertsimas, who is the Boeing Leaders for Global Operations Professor of Management, a Professor of Operations Research, and the Associate Dean for the Masters of Business Analytics at MIT. We have Professor Effie Vallena. She's Professor of Bioethics at Swiss Federal Institute of Technology in Zurich. She's also she's an expert in the intersection of medicine, data, and ethics. So it will be interesting to capture also the ethical dimension of the applications of AI technologies. And we have the in-house expert that could not be missed from this event, Reinhilda Brugellers, senior fellow at Bruegel, and she's working on innovative technologies, and also her research interests include health markets. She recently published an interesting paper on the market design for the vaccine for COVID-19. So I will give the floor to the speakers for what is expected to be a very interesting discussion on the topic for the following 60 minutes. Before that, let me inform the viewers of this live stream that they can ask questions through the Slido platform. The link is on the event page. The code is #healthcare. So please, throughout these 60 minutes, do not hesitate to share with us your thoughts and your questions. And please also indicate your preference to the questions of the others using the like button. Towards the end of the event, I will look at the questions and I will select some of them depending also on the time we have. Without a further delay, Dimitri, the floor is yours.
Good morning, good evening to the participants of the seminar. I would like to discuss personalized medicine today and demonstrate at least some examples where artificial intelligence and healthcare has an interesting and important future, in my opinion. So my first remark is that medicine today is not personalized. Patients, by and large, patients with similar symptoms diagnosed with the same disease are given typically the same treatment independent of their history, biological variations, and potentially hereditary factors. In addition, another remark I have, medical education has not fantastically changed in the last 100 years since the 1920s, that the current model of educating doctors in medicine in Johns Hopkins has started. In particular, today's young doctors do not really know in some depth AI technologies, even though they are increasingly present in the practice of medicine, and I expect they will be even more so in the future. So the questions that I would like to ask is, can we improve outcomes for patients by personalizing treatment? And then how does this affect education of the new generation of doctors? Also, closer to my field, how should we educate the new generation of analytics graduates to be closer to understanding the effects in medicine? So the overall aspirations, as it is obvious from my remarks, is to improve outcomes for patients via personalized medicine, to affect medical education, and also to affect analytics education. So I don't have a lot of time, I chose two topics. First is a paper that I wrote a few years back that appeared in Diabetes Care, that's called Personalized Diabetes Management. And the second, something that I completed very recently, risk scores for COVID-19 patients. And I won't have a huge amount of time for this topic. So if people would like to learn more about it and some other work I've been doing on the COVID-19 effort together with a large group of my doctoral students at MIT, I would refer you to covidanalytics.io. So first, on personalized diabetes management, I would like to say first that diabetes is a personal interest of mine. My mother, my grandmother, my grandfather, my aunt, all my mother's side of the family have actually suffered from diabetes and died from it. So, so this is not just an academic topic for me. It is, I have known the disease since I was a young boy in Athens, growing up in Athens. So the particular topic is utilizing data as appropriate for an artificial intelligence investigation. Our starting point is electronic medical records for about 1.1 million patients from a hospital in Boston, the Boston Medical Center. Out of these patients, these are type 2 diabetes patients, you expect of the order of 9 to 10%. On the other hand, which roughly is about 100,000 people, but we selected 10,000 type 2 diabetics patients, we have a lot of data, namely they have a high density of data. Something about this hospital is that this is the hospital for the underprivileged in Boston. And because of that, many of the patients have almost the totality of their care in that hospital. So for patients that do that, we have fairly strong data over a long period of time, in this case from 1999 to 2014. The patient characteristics are demographic information like age, sex, race, language, religion, and marital status, medical history, for example, records for BMI, hemoglobin A1C, which is the key indicator for the glucose level in the blood, creatinine levels, and so forth, and the treatment history. What is the medication records? Just to give you a sense of the demographics of the patient, this is not a typical US hospital. This has, as you see, mostly African-American people, about 58%, Hispanic is about 15%, and the white population is about 16%. The BMI is high, it's 33, and for the population of 10,000, the hemoglobin is 7.9. I remind readers, remind the audience that levels between 6 and above 6 are diabetic patients. And the average age is about 60. Just to give you a sense of the data involved, so this is a trajectory of a single patient. This patient we'll see again in the end of the presentation. So this patient, this black line indicates over time from 1999 to 2014, almost continuous coverage, the level of hemoglobin A1C. So, and you can see that it stays relatively constant, occasionally with very few exceptions, and around 9+, which means it's not a well-controlled diabetes, even though it has been going on for a long time. Then the colors indicate the history of the drugs. We know, for example, that continuously the red indicates insulin. The person has been prescribed insulin over this period. And in the beginning, he was also prescribed an oral medication, sulfonylurea, that was later changed to metformin, which is a generic drug widely used as the first line of therapy for diabetes. So I hope this is clear, that this is the level, the type of data we receive. Of course, we receive far more data, but that's a pictorial representation of the time series of the data. So the key decisions that we have to face are, so what we know that there are about 48,000 unique patient visits, about 10,000 patients of the order of maybe 5 visits per patient on average. Of course, there's variability on that. And what we'd like to do after every visit is to decide what treatment to follow in a personalized manner, as the title suggests. And the outcome of interest is to improve, to make it smaller, the average post-treatment hemoglobin A1C in the period 75 to 200 days after it. So in every visit, we observe what I call the ground truth, the standard of care treatment, namely what the provider prescribed, because we know this in the data. Typically, it's a continuation of the current line of therapy. In the data, out of the 48,000 visits, we have selected, there are a lot of treatments, of course. This is a standard of care at the Boston Medical Center for 15 years. Therapies from no regimen prescribed to about 5,500 of these patients to metformin monotherapy, about 20%, insulin, and so forth. There were 13 distinct treatments. Of course, the 13th class is all other multi-drug therapies that have very little data to make use of this information. But the major treatments, the major categories, metformin monotherapy, insulin monotherapy, combinations, and so forth, are here. So I would like to illustrate the key idea of this presentation. I chose this because it's while it's relatively simple to explain. So imagine that you have the characteristics of the patient of all patients historically in the database. For example, let's say for purposes of graphing, we have the previous hemoglobin A1C as one of the previous characteristics and the age of the patient. So for example, the black dots indicate various patients associated of the past in various visits. So a particular black dot has associated with it what treatment has been applied to this patient, has been prescribed, and what have the outcomes been. So imagine now we are contemplating in giving a particular treatment to this patient, let's say insulin. This patient has not been taking insulin in the past. So we take all patients that have not been taking insulin in the past and were given insulin. These are the subset of the patients indicated by the black dots. And then the red dot is the current patient of interest. This is a particular hemoglobin A1C that we had in the previous month, previous visit, and the age of the patient. Of course, there are many other. It's a multidimensional graph. I just indicate two of the coordinates. And what I do is I take the K, we use K equals to 50, the 50 nearest neighbors. In the beginning, you can think of it as Euclidean distance, the distance between the red dot and the black dots. Among, let's say, 1,000 such patients, we take the closest 50. Now we utilize more sophisticated than Euclidean distance. What we've done is we utilized weighted distance, in that we built a model that predicts, let's say a regression model, that predicts future hemoglobin A1C based on these characteristics. This regression had a particular coefficients. So these weights of the coefficients is what we weigh the distance. For example, we weigh the distance on the coordinate previous hemoglobin A1C times the regression coefficient. So if the regression coefficient is high, namely that previous hemoglobin A1C has a big effect in predicting future hemoglobin A1C, then this distance and so forth. So we create, therefore, in a sense, the black dots in the circle are patients like me, patients that have similar characteristics, not identical, but have taken insulin because insulin is what we are contemplating at the moment. And we haven't, so then we would stipulate that these patients inherits the distribution of outcomes for these 15 nearest neighbors. We repeat this process for the other 13 treatments. So therefore we have 13 distributions of possible outcomes that each of them is patients that was prescribed a particular prescription, a particular drug. So as an example, in terms of weights, the previous hemoglobin A1C has a higher weight. Whether another factor is the patient currently on insulin or not, the mean BMI, which is an indication of fat in the body, and so forth. So you see the various factors that matter. We ran these regressions. The regressions were reasonably accurate, not fantastically accurate, but reasonably accurate. And the personalized treatment is as follows. Let me illustrate it with respect to this graph. So, so this patient, this is the initial patient that I have talked to you about, is an African-American female, age 62 years old, whose current hemoglobin A1C is 10.1, and the current regimen is insulin. So that's the current patient. We applied this process for a variety of treatments. For example, we say, suppose we continue the current treatment of insulin. So we repeated the analysis, and we found that we expect that the mean hemoglobin A1C in the next visit, in the distribution of patients among the neighbors, is 9.4. Lower, but not particularly low. For example, insulin and non-metformin oral agent was 9.2. But interesting enough, metformin, which is typically a therapy, which is first-line therapy, is expected to be 8.3, significantly lower, which is the lowest among the others. And this is exactly what we recommend. Admittedly, this is an unusual treatment. I picked this example because of this unusual characteristic. So what this algorithm observes, the reason it's unusual is because people that are in insulin have already made the transition to insulin, continue to do so. And then we say stop insulin and go to monotherapy metformin. Why is it the case? So the algorithm, as you observe, if you observe the trajectory of hemoglobin A1C of the patient, is even though the person takes insulin, is roughly at the moment 10.1 and more or less constant over time. This likely suggests non-compliance, namely the doctor prescribes insulin, but quite likely the person does not take it, the patient does not take insulin. And the reasons for that is that for those of you in the audience that might have some experience with insulin, you have to measure, you have to estimate the quantity of food you have to inject yourself, you have to estimate it exactly or reasonably, and any errors can create hypoglycemia, which is a very dangerous, threatening complication that might actually cause your life if you're not careful. Whereas metformin is an oral agent, just a pill or 1 or 2 pills that you have a day, which is much easier to administer. It's not perhaps as effective as insulin, but given that insulin for 15 years has not been effective, so the algorithm detects these are through its inner workings. I'm now sort of verbalizing or explaining, giving intuition on the solution. Suggests that by simplifying the way the delivery by going to metformin, you can expect a 2 points decrease approximately in hemoglobin A1C. Of course, this is not the only way that the reason this is personalized is that this particular, it takes into account this patient who apparently has compliance issues. So then we repeated of course, the only way to see if the algorithm works is to do a clinical trial. And we are in the process, in the middle actually, of doing a trial in a local hospital. But we also applied it to new data that the algorithm has not seen. And the algorithm we have utilized is that if the projected improvement is more than 0.8, so let's say from 7.8 to 7 and higher, then we make the change. Otherwise, we don't make it, so that to prevent small changes and robustify the process. So we have found that about a third of the patients, the recommended change, improves by more than 0.8. So that's the algorithm. So if it's significant enough, we do it. If it's not significant enough, we don't. And we, in the data that we have seen out of sample experiments, we see that the hemoglobin A1C in this personalized way is reduced by 0.44. And this is significant, the p-value of 0.1%, fairly significant that is. So in other words, we have some evidence that this indeed provides a reasonable improvement of care. So, so this has the various other changes. You will see, so what, from what to what. So how many patients taking one therapy and will go to another therapy. Time is short to explain all the cases, but it's far richer than just detecting non-compliance. It also observes that certain people, it might be better for them to use insulin. It might be better to use sulfonylurea and insulin and so forth. And you can also do subgroup analysis. You can have a deeper understanding of what is going on. But I do believe it shows, I would say, the promise that personalized medicine has in the case of diabetes. Diabetes, as perhaps you know, it's quite a bit in a high degree behavioral disease. So behavior can actually materially affect the outcomes. So and I feel since then we have applied this in multiple other diseases, in oncology, in cardiovascular disease, in blood pressure, and so forth. And I feel strongly that personalizing treatment can make material difference by leveraging all the data, electronic medical records, imaging reports, genomic information, and if you are interested in more information, you can look at my website. You can see several papers in particular areas of medicine. In the few remaining minutes, I hope I have 2 or 3 minutes, I would like to tell you a little bit about some very recent work I have been doing on COVID-19 patients that was motivated by the following observation. We received data from multiple hospitals from the US and Europe, and the key objective is to try to predict whether somebody has the infection by just without doing tests, but just from AI. And then once you come to the hospital, what is the probability of mortality based on the symptoms you might have in order to prioritize care. So I don't have a lot of time to explain the results, but please take a look at covidanalytics.io. There are 2 calculators there, one for infections and one for mortality. And we utilize them, as I mentioned, data of the order of 3,000 patients, primarily from hospitals in Italy, Cremona, in Spain, in Greece, in the US, Hartford Hospital, and the partners system. Just to demonstrate one aspect, we utilize a method that is called XC-Boost, for those of you who know, but the accuracy of this method is very high. And we have found that for mortality, key aspects is the age, BUN. BUN is a measurement that captures the function of the kidney, oxygen saturation, CRP, which is another indicator that shows the overall condition of the patient, and so forth. So if we have lab values, namely blood tests, the mortality calculates very high, and without lab tests is still quite high. We have validated this using data from one hospital and then demonstrated in multiple others. Currently, the method is being used in multiple ways. First, in hospitals that for triaging patients and prioritizing resources. And also, and the infection calculator is utilized by several companies that have many thousands of employees as a pre-screening mechanism of giving priority to which patients to ask for measurements. Of course, this is personalized, and that's an indication of how predictive methods, the previous one was prescriptive methods, can make a difference in coping with the disease. I'm currently working in incorporating the prediction for infection with in an environment with wearables, that all these variables, temperature, blood pressure, oxygenation level, heart rate, is automatically measured, and therefore a continuously monitoring system that tries to give early warning. I hope I gave you a bit of an understanding of the work. I thank you for your attention. George?
If I may, would you like to spend 1 or 2 more minutes describing the important factors in the prediction?
Yeah. So if you have labs, so if I may, I would like to perhaps go directly to the website and go directly there, if that's okay.
Sure.
That could be, I would say, clearer to the audience. I need to find the website for a minute. But they are BUN, as I mentioned. I need 1 minute to change environments.
So let me say that it is clear that this personalized treatment and also healthcare in general can create an added value, as you clearly illustrated from your example in diabetes. It is a very important point to have these personalized applications that they are facilitated by these new technologies.
So this is in response to your question, George. So let's say you have, this is something you can do from home. Do you have laboratories? No. Let's say the gender is male. The age, let's say, is 72. The temperature, let's say, it's 102. The heart rate, let's say, is 90. The oxygen, let's say you don't know your oxygenation level, but do you have, let's say, shortness of breath? Let's say yes. Okay. And let's say you have comorbidities. Let's say you have chronic kidney disease, and the mortality risk is 40%. So these are people that have high temperature. They have, and if you look at the factors, is age, very important factor. Oops. Oxygenation saturation, the temperature, gender matters, men being in more vulnerable state, heart rate, diabetes, and so forth. So these are the characteristics for this case. If you have lab values, then it asks for more questions. So these are the various questions: gender, age, saturation, heart rate, alanine, creatinine, sodium, blood, urea, nitrogen, and so forth. You see all the factors that are being, even if you only know, let's say, 65% of it, a third. If you don't know a third of the factors, the algorithm runs. If you don't know below 50%, the algorithm says I don't have enough information. So hopefully you get a sense.
Yes. Thank you very much, Dimitri, for this elaboration. It becomes clear that this personalization and the added value is brought by using different variety of data as an input, relevant data, to which can help the algorithm to derive the desired output given its specific tasks. However, all this personal information can also create some issues from ethical point of view. So I would like to turn to Effie to hear her thoughts on what are the associated issues and how we can address them.
Thank you, and thank you for the invitation. Glad to be here today. So I'll just have some general remarks, and then also maybe connect to some of the very interesting research and projects that we just heard about. The area I work on is more broadly like what people call artificial intelligence in healthcare, and some of the work we just heard about obviously is part of it. So I have two caveats in what I'm going to say. The first one is when we talk about data uses for artificial intelligence in healthcare, artificial intelligence means a lot of things to a lot of people, and it tends to mean different things to different people. And we have this rubric that I think makes it difficult to speak about the ethical issues because the ethical considerations are contextual. So it really depends on what you're doing with what you're doing it, instead of just sort of broadly putting everything, in one basket. So that's one caveat, that it really depends on what exactly we're doing and with what and for what purpose, in order to determine what are the ethical considerations that we should be mindful of. The second, I think, is sometimes we hear about a lot of opposition, concerns about what AI is going to do to healthcare, a lot of kind of flip side of what we just heard, not the promise, but rather the problems that we're going to face. And to that, I want to say that given the potential that seems to be obvious in various applications of analytics and whatever you want to mean by artificial intelligence, I think we do have an obligation to explore it and certainly see how it can improve the state of healthcare and hopefully eventually the state of health for all people. And so with these two caveats, I'm just going to go on some of the typical challenges that we're mostly seeing when we're thinking of deploying analytics and algorithms, machine learning, and other kinds of technologies under the rubric of AI in healthcare. So the first one is about the safety and reliability, and that's something very a classic concern in medicine and healthcare. Is whatever we do safe? whether it's a pharmaceutical intervention, pharmacological intervention, or another type of intervention. Is it safe and is it reliable? Is it basically going to do what we, or for the most part, what we hope it to do? The second one is usually a concern that has come up many times, whether the data that we have used, whether there's bias in that system that we're using, because the system has picked up bias from the biased data that have been used, and eventually gives us a product that maybe perpetuates existing problems instead of solving some. There have been also concerns about how transparent some of these systems are, and transparent in two ways. People talk about, do we know how they're actually used in let's say in clinical practice, but also often transparency is linked with whether the codes are open source, whether there is explainability of those, whether we can actually say what exactly happens. Another concern relates to issues of accountability when we're using those systems. So the concerns go from the development to deployment, and I'm just covering as many as possible here. How accountable are how accountable are those developing them, but also when we're implementing them in healthcare? What exactly constitutes accountability in this case, given the types of interventions we're talking about? These are not uncommon in other areas, and not only in the area of medicine and healthcare. Some more distinct, perhaps, concerns here are interventions like these, whether they're actually going to have an effect in the patient-doctor relationship or healthcare provider-patient relationship that has an importance in medicine and healthcare. We speak often of the therapeutic relationship, because part of this process of treatment is not simply the intervention, but also the relationship, the trust with the physician. These are some of the sort of general kind of concerns that we're thinking about when we're talking about those systems. But I want to focus on three of them that I think they're quite relevant, and they link us back also to what's been happening also with the COVID, the response to COVID-19. So one of the things that we've been seeing, along with the hype about how much data analytics are going to do for health and healthcare, is this bigger question of evidence. Is our hype or our hope or our optimism matched by evidence that these systems actually have the effect that we're hoping them to have? And that includes also the development of standards, validation methods, and then pure effectiveness. Something, again, that it depends, always it depends what is it that we're talking about. But in broad strokes, this general idea of evidence that the, let's say, the algorithm that we're using, be it for a prediction, in triage, or be it diagnostic, is this really, does it do what we really want it to do? And across the board, we're seeing some difficulty with that. In the presentation before, we heard about a clinical trial which is underway for this particular algorithm. We saw also that I think you mentioned that you're using it in new data sets, not in the data sets that they've been used to develop the algorithm, which again is about a way in which we can assess it's a standard, but also a way in which we can assess, does this really work, and does it work most of the time, not only in data similar to what it's been trained with. So I think we still have an issue with what constitutes evidence in these kinds of interventions and technologies. What are the standards that we need to have in order to determine it, and how do we frame the concept of effectiveness in these kinds of systems? And here I want to bring one example that is related very much to personalized medicine, except from the applications that are used in a clinical setting, in a hospital or in another service provision center. We often said that what we want to do with the data that we collect from each person is to help the person manage disease, do things, predict, prevent disease before we get to the point where we get to have them in the hospital and need the treatment. That's actually one of the big hopes of personalized medicine, that we can shift to the prevention prediction and move away from treatment that are demanding and costly in all sorts of ways. Now, one of the tools that we seem to be thinking about that's going to do that is a lot of health apps that people will have and will be able to using and in order to understand themselves, prevent and affect behavior. And health apps, except of those that are classified as medical devices where they go through some scrutiny in order to be approved, we have a whole array of other kinds of apps that are promising a lot of the things that would like to happen with personalized medicine. And yet what we see in many, many studies is, again, that the evidence about the effectiveness of those apps is very limited, if any. There's been a huge effort also by national health services, for example, in the UK, to develop criteria where we can see whether actually the value of this app in the sense of effectiveness is there. And one set of standards for understanding, for thinking of the standards, validation and effectiveness is, do they do the thing we want? Would they reduce diabetes if one were using it? Or could they help people manage diabetes better than without? Beyond, we get to the pharmacological intervention. Another set of issues with these technologies, particularly apps, is what about the privacy, or what about the data protection? And what we've seen in many, many studies is that several, again, of those wellness apps, even those classified higherly as a health apps, they do have various issues with how they comply with data protection regulation. And even if they comply with data protection regulation, how they find ways in which, for example, they don't inform people appropriately, or they share data in ways that they're not exactly clear. So we're seeing there that, again, we are probably far away from meeting standards and requirements about safety and effectiveness. And I use safety more broadly than the actual physical safety, safe in terms of also data protection. So there, I think there's been some work trying to address some of these issues, but in my view, that's one big challenging area. The second set of issues I group under what I call data governance. We heard obviously about millions of EHRs, EMRs, depending on how you call them, that need to be used in order to develop those kinds of algorithms and train them appropriately. And what we see again and again is that it is not as clear. Some institutions have data governance in place, some institutions don't. It's complex and complicated to share data. Still today, we've been thinking about and talking about data sharing for years and years. There's been guidance, there's been regulation, there's been all sorts of things. But what we keep hearing, what we see, is when we move towards broader, wider data sharing, conditions about doing this in an appropriate and respectful way, there's still a bit of a patchwork. And that, to me, is also a big challenge, because I think unless we get the data governance sorted out, I'm struggling to understand how we can get the AI health governance in a better place. Some people separate the two, and I think there might be some sort of practical reasons separating the two. But in my understanding, this is a continuum. If you don't get proper, if you don't have proper data governance in place, without the data, it's very difficult to develop the algorithms that you need to have, to test them, to validate them, et cetera, et cetera. So speaking of ethically appropriate interventions that have been generated or been developed on the basis of fuzzy rules about the data in which they were used, I think that's difficult to defend. And again, here, there's been a lot, there's guidance, there is a lot of discussion and debate. But every time we're thinking about more data or different kinds of data, you mentioned earlier electronic health records or genomic data or all sorts of the data from wearable devices. The broader we go in terms of types of data, I think the more we see that there are serious difficulties in how we appropriately use them. Even in the context of the GDPR in Europe with the General Data Protection Regulation, again, still there, we're trying to figure out how this whole thing will work. And the third point that I'm personally concerned with is in the interventions, and what we've seen also recently, and we see it very much with COVID as well. When we look what happened with COVID in many countries, we saw how much it exposed deep structural problems in our healthcare system and in our societies more broadly. We see structural injustice. We've seen that in healthcare before we saw it elsewhere. But I think with the COVID-19 playing out the way it did, that has become even more clear that was ever before. And so my question, I guess, is, are these technologies that seem to be so promising going to make a difference in those kinds of injustices? Or are these going to be fed into a system and perpetuate them and make things worse? Now, you could say, you can ask this question for any technology. Why singling out this one? The reason I think I want to single out this one in terms of how it can perpetuate or perhaps amplify injustice and unfairness that we've seen breeding in many places around the world is because of its scalability, that I think it's hard to compare with other interventions in medicine, even drugs, even generic drugs. It's just harder to produce. Applying algorithms, I think it will be, it's faster, it's easier, it scales in ways that we haven't seen before. And so if it scales the way I understand it to be scalable, it fascinates people as well in ways that maybe other interventions might not. Can we guarantee that it is designed in a way and it's implemented in a way that it is not going to amplify and perpetuate and perhaps amplify existing inequities and problems we have seen so far? And that's, again, I think for me, COVID-19 has done something like that. I was looking at two things. You mentioned the triage, the scoring system, which essentially what it does also, it triages patients, right, in terms of priority of resources. And I've got a few questions about this, but maybe for the discussion. But I was looking at another system that's happening, that's in the works right now, the contact tracing apps, the proximity tracing apps for identifying patients, people who have been exposed to infected cases. And again, there we're seeing the three problems that I mentioned. One, that how can none of these systems that we're ready to deploy has been validated in terms of, well, actually there is no acceptable standard. We have some standards. We know very little about their effectiveness because we didn't have time to test them. The virus is running around, so we've got to do something about it. Yet we're confidently rolling them out. In terms of data and data governance, again, there is a big debate as to which data we're going to collect. There's a big debate as to whether these systems will be centralized, decentralized, the roles of the private sector, etc. And the third one, we've been again questioning the possibility, the digital divide, in terms of even in countries where we have high penetration of devices, of high-tech devices. Again, there we have parts of the population that are unable to use the technology. And so again, I think those three things in my mind, those three considerations and challenges, keep coming up when we're looking at systems around the, well, under the rubric of artificial intelligence that we hope very much to improve health. So I'll stop here, and I have a few questions for our presentation presented earlier in the discussion. Thank you.
Thank you, Effie. Since you have your own questions for the presentation, I will move directly to Reinhilda to make sure that we will have some time for questions in the end. So Reinhilda, we have seen, we have already discussed about specific, how in a specific way, how AI technologies can help. There are also some some issues on how they are implemented. What are your thoughts from your work and experience with these markets?
Yeah, thanks, Georgios, for giving me the opportunity to talk about this. So I will definitely also look more into the research component and the innovation component and how we can use AI for that. So I think the potential for AI and big data and healthcare, that's definitely obvious, already mentioned by the two speakers before. Also, personalized medicine, that's really the way forward in medicine in general. And if you combine AI for personalized medicine, I think it gives even more, shows even more the potential for AI technologies here. But when we talk about personalized medicine, that goes really beyond just identifying broad classes like age, sex, race. So it's really very personalized and goes back to your DNA structure. That's really very individual, and how you can actually go to that level of personalization and not just categorization here. So I was wondering to which extent you can go in your algorithms also to that real level of personalization beyond those obvious characteristics, and also the extent to which, because a lot of these characteristics are basically, yeah, you can identify correlations, but we still don't know enough for personalized medicine to really know what the effect is of these individual characteristics on the health of people here. So for me, what's really important is to use also AI in order to advance our knowledge on this and to go away from a black box, but to also understand what's in the black box here. We definitely need more knowledge to understand in order to be really going into personalized medicine. And I think also the really growing area is indeed systems biology, which combines a lot of this AI in order to understand better the systems. And that's the way forward too. For instance, the National Academy of Sciences has identified that this systems biology, that's one of the really critical areas for future to be important, to be leading in. And what they really are afraid of is that China will be very much winning in systems biology. So in that respect, it's definitely an area where we want to make improvements on. And then I was wondering to which extent this better knowledge of systems, that would also require actually much more big data on treatment, but that should flow into the research area as well. So I want to make a better link into the use of this big data for improving treatment, which is basically what you're focusing on, but also to make sure that the use of those insights from using AI for better treatment would also flow back into research and development for new drugs and improvement of new drugs as well. So because what you're using is all FDA approved drugs, as far as I understand, in your AI algorithm. And so indeed, both the federal, so FDA, as well as the European EMA, they have set standards for identifying safety and efficacy. So you don't need to care that much about it anymore because they're all approved. Unless, of course, you're starting to combine, then I think there's definitely also a safety and efficacy. But so I was wondering to which extent, if you would really go and apply your algorithms to clinical trials for new drugs, would that be the same AI algorithms that you can use? I guess you would need completely different confidence intervals that would definitely also satisfy these standards as well. And then final issue I'd like to again bring to the floor, also Effie already mentioned, then is this whole issue of access to data and the need for data sharing as well and privacy. That's definitely important because we want as big data sets as possible. Should also be as international as possible because you really want a representative set of patients. Of course, if we talk about research, you can always call for a research exemption, which makes it easier for using data and data sharing. But once you go into development, that's already much less clear. So all these issues of data sharing and access to data definitely is an issue. And what I'm particularly also a bit worried about is that, so we see that a lot of these new drugs developments are done by small firms initially, and then they're taken over in later stages by big firms, larger firms. That's for the moment still big pharma. Because their central advantage is that they have deep pockets and they have the complementary assets, and that's why basically big pharma dominates a lot this market. If we move to data sharing and data access as a very important part of personalized medicine, would that give an even stronger advantage to big pharma because of the big size, they will also have access to, or easier access to more data on different drugs. Or would it shift to other newer players? But would that then be big tech here who has the data and the health apps, etc.? That would still be concentrated in big hands, but no longer the big pharma, but the big tech. And still, it would still, in both cases, be concentration in big firms. And would that still allow for enough room for these smaller companies to be able to use and get access to the data for developing new drugs and new therapies here. So overall, I guess my major point is that we need to also look at the potential of AI beyond just improving existing treatments here, but also how we can use that to feed back into a research of understanding personalized medicine better, and to use that for being able to develop more new drugs and improve both therapies as well as diagnostics, but also for new drugs as well. And whether that would be the same type of AI that you can use for existing drugs versus these new drugs. But thanks for the challenging presentations.
Thank you very much, Reinhilda. There are a full range of topics and questions raised so far, Dimitri, and there are some more. But before we go to a second round of short discussion, do you have any brief comment, or do you want to briefly summarize some of the main points you want to make in reflecting to what Effie and Reinhilda mentioned? You are mute, Dimitri.
I would, but given the time, it's better to leave the floor to the audience so we can have at least some dialogue.
Okay. One question that has already, I think, mentioned and to some extent pointed out is what would be, if any, the privacy conflicts with implementation of AI to create personalized treatments?
I mean, all in the applications I have been involved, and there have been many, they are all HIPAA compliant. The data are anonymized. I would say the privacy, I mean, the rules on building IRBs and HIPAA and so forth are fairly, at least in my experience, are fairly elaborate. So admittedly, obviously there is always room for abuse and so forth, but at least as far as these algorithms are concerned, they have been developed through anonymized data. And the only thing that then matters to the patient is the overall algorithm. We don't know anything but other types of details about the patient.
And how is focusing with on anonymized data to address privacy concerns can be helpful in terms of predicting and reducing the risk of COVID transmission?
I cannot simplify and say there are no privacy concerns, but one, as I think Effie mentioned this, I mean, there's often a trade-off between, I mean, this is at least in the United States, this has led to about 120,000 deaths and 100,000 plus deaths already and growing, I would say I err on, if there is an issue, which at the moment I don't fully see, but if there is an issue, I will err on human life than anything else. If I can save a life, potentially affecting some aspects of privacy, I'd rather save a life. That's my own sense, of course. Other people might have different answers.
Effie, do you want to comment on that?
Sure. Well, I think, again, there are always going to be those concerns with data protection, and there's going to be concerns with privacy, and that's important that anyone who works in this area is mindful of that. But the fact that data are used doesn't automatically mean that there's a problem with privacy. So, for example, for many of these, well, there are forms of like anonymization and other techniques that can take away some of the problem. But there are things like having asked the people whether they are okay with using their data for various purposes. And so what we see often is that people who are asked, patients who are asked, can we use your data for research purposes from bona fide researchers or within, certain countries or institutions? The majority of people actually tend to say yes. Only a fraction says no to this. But the question is always, have we set up a system in which we get those permissions that people, not just patients, all of us, are considered the institutions involved to be trustworthy, so we know what they're doing is going to be with conditions in place. And then, of course, the biggest question of all, because I've been doing quite a lot of work in how what people think about, uses of their even genomic data that, as Hilda mentioned, even more personal than personal. People are very concerned about how the benefit is distributed. And not only to them, if they're going to get a personal benefit, but is the benefit of all of that fairly distributed or not? And I think these are issues that actually are the ones that can help us get away from this very binary and quite problematic. Is it privacy or health? Is it privacy or death? I think there are different ways of looking at that are more constructive and helpful.
So I'd like to add to the issue of privacy and access to data, also this incentive for data sharing. As I already mentioned, I think it's very important that also the data are shared enough, if only for research and for improving. And so it's not necessarily that because there is access to data, that there will be incentives enough to share the data, definitely in this kind of industry. So added issue.
Let me ask the final question from the audience. What do you think is the greatest potential success for artificial intelligence in its applications to medicine? A forward-looking question. Do you have a specific application or a specific field in mind that could be can bring the revolution?
May I take it? So, first of all, every area of medicine will be affected, but particularly in the area of oncology, if you look at what we have been doing for almost 50 years, is we give chemotherapy or more recently more targeted therapies, but chemotherapy for 50 years to everybody, the same thing. We have personalizing the treatment, take into account genomic information, because cancer in particular is not one disease. Cancer is multiple diseases, but we have put them into one umbrella. I think on oncology, in my view, the best chance I see in curing cancer in the years to come is through personalizing treatments, utilizing multiple technologies, genomic information and AI, utilizing early detection via AI and imaging that are far more accurate than humans, electronic medical records in combination with all of the above. So in my view, I see a future in which all the data that currently humans use in combination, reports, images, electronic records, genomics, together can be utilized. It's not a problem we have solved yet, but you asked me about the future. I would say that's the future that I believe is an exciting future and would leave to a significant reduction in mortality and suffering from humans.
Thank you, Dimitri.
I'd like to add to that indeed the combination of AI with personalized medicine just makes the point that you don't treat individual diseases, but that you see the whole system actually. And it's the interaction between many of the diseases that's really the power of personalized medicine. And that's where exactly you would need AI and where AI can be the biggest push.
Thank you. Effie?
Yes. So for me, I think Dimitris is better placed to talk about the specifics of the technology. But for me, the revolutionary technology and intervention will be the one that actually improves the health of the many people whose health is not improved. And with breakthroughs, again, what we watch out is who is the recipient of the breakthrough. It's more of a social problem than a medical problem. But I think that how we're thinking about what a breakthrough is and how it revolutionizes healthcare, it's also how equitably it's distributed and how it raises the health of all people.
Clear. Thank you very much. There are so many other topics, and were also points raised that we didn't have to go the time to go into them. Thank you very much for your insights. I hope at some point in the future we can repeat this session, this discussion, and we can continue from the point we stopped. Thank you for your time, and I wish you a pleasant day, and do great research, do great work, because society needs it.
Thank you.
Take care.